última parte de esta reunión va a ser sobre el apasionante tema de las epilepsias autoinmunes y tenemos a la siguiente ponente es la doctora Tiziana Granata. Ella es la jefa de la unidad de epilepsia del Departamento de Neurociencia Pediátrica y del Instituto Neurologico Carlo Besta en Milán. Y bueno, es bien conocida por todos y también ahora mismo es miembro del Comité Científico de la Liga Italiana contra la Epilepsia. Bienvenida, Tiziana.
Okay. Thank you, Angeles. Thank you, Mar, for inviting me. And I'm very happy to be in Spain once again. Not this afternoon. Okay. The title of my presentation would have been Epilepsias autoimmunes, but I did autoimmune encephalitis, and this because I'm not really sure that autoimmune epilepsy do exist, whereas I'm sure that autoimmune encephalitis do exist. And we'll discuss later with Mar on this topic again. So I will talk about autoimmune encephalitis, which is the definition. I have to change my eyeglasses, sorry. Otherwise, I can't see my slide. So what are autoimmune encephalitis? With this term, we refer to a group of inflammatory brain diseases that are characterized by prominent neuropsychiatric symptoms and are associated with antibodies. The antibodies are against neuronal cell surface protein, ion channels, or receptor, and these antibodies bind to the extracellular epitopes of cell surface protein and cause reversible neuronal dysfunction. And we have the evidence for the direct pathogenic effects of a number of antibodies, which are listed here. The autoimmune encephalitis shares some common characteristics that we have to notice to try to make the diagnosis, to think about this. First of all, there is a wide range of age of presentation. They go from childhood to old age, and there is a core of clinical and paraclinical signs that can be summarized as follows. There are seizures, the acute or subacute onset of seizure, of psychiatric symptoms and change in behavior, memory and cognitive disturbances, sleep dysfunction, association with movement disorder, decreased level of consciousness, and dysautonomia. And typically, in autoimmune encephalitis, there are no systemic manifestations other than autonomic dysfunction, differently from what we see in systemic autoimmune disease like lupus erythematosus systemicus or so on. The paraclinical feature as well share some common characteristics. The G may be characterized by focal or diffuse theta delta activity, as you can see in the first, which is this one? Which is the pointer? Okay.
Pointer is the right bottom.
This? Okay. As you can see here, with this delta activity, mainly on the frontal region or in this other patient, or may be characterized by periodic delta activity mixed with some sharp, or by low voltage activity and discharge of epileptic activity, for example, here on the temporal lead in the patients with limbic encephalitis. MRI may be different according to the different etiology. For example, in NMDR encephalitis, in most cases, MRI is normal or show specific abnormalities. In limbic encephalitis, typically, we have the alteration of the mesial temporal lobes. In GABA-A receptor encephalitis, we have diffuse and patchy signal abnormalities. So, This is a list of this is taken by a position paper, an important position paper that has been published on Lancet Neurology a few years ago, where where the encephalitis associated with neuronal surface antibodies are listed, and these are the more frequent encephalitis, NMDA receptor encephalitis, GABA, and LGI1 encephalitis. And we enter into further details soon after. But there are patients for which we suspect autoimmune encephalitis, but in whom we do not find antibodies. And so these authors propose criteria to define possible autoimmune encephalitis in absence of antibodies. And again, we have to have subacute onset of working memory deficit, altered mental status, psychiatric symptoms, seizure, and at least one of the following: CNS findings, new focal, seizure not explained by other causes, pleocytosis in CSF, and MRI features of encephalitis, of inflammation. And of course, the exclusion of other causes. In most cases, I think we can summarize autoimmune encephalitis into three main groups. We have NMDR encephalitis that has a particular clinical feature, and I will go into details later. And we have other antibodies, LGI1, GABA-R, GAMPA, ACASP, that typically present with the limbic encephalitis. And then we have the more epileptogenic of all these encephalitis, that is probably the GABA receptor-associated encephalitis. What is limbic encephalitis? I think all of you well know the limbic encephalitis that is characterized by the subacute onset of working memory deficit, seizure that point to temporal involvement, and psychiatric symptoms that again suggest the involvement of limbic system. Typically, there is bilateral brain abnormalities that are disclosed, that are shown at the MRI of the temporal structure. And we must have at least one CSF pleocytosis or EG with epileptic or slow wave activity involving the temporal lobes. The autoimmune limbic encephalitis, more frequent, is that associated with LGI1 antibodies that affect adults. Less than 10 children have been reported, is rarely paraneoplastic, affects temporal lobe structure, and the symptoms are symptoms that point to the limbic involvement, and the particular symptom, there are faciobrachial dystonic seizure. Faciobrachial dystonic seizure must be recognized because they are prodromal to limbic encephalitis in most cases, because antiepileptic drugs are ineffective, and because the immunomodulation, the treatment with immunomodulation prevent the evolution to the full-blown limbic encephalitis. And I would like to show you a short video. Don't you have the mouse? It's a video, yeah.
Let me help you.
Okay? No. Does not work. Is it going? Yeah. So is very fast movement. Is it going? Is it working? It don't seem it's working.
I guess that yes, but it's on the other screen. Oh, it's a stop.
Okay, have you seen? And I think you see on the other side. Maybe it is finished, okay? Does not matter. So you have to recognize this movement with facial and brachial movement. GABA antibodies encephalitis is rare, but it's very epileptogenic with recurrent recurrent seizure and epileptic status. But now I like to move to the more frequent encephalitis, at least in children, that is NMDR encephalitis that has been, as you all know, described here in Spain by Professor Dalmau and Dr. Grause, I think. The target of these antibodies are the subunit of glutamatergic and MDR receptor that became depleted, and we have the release, the increase of extracellular glutamate with excitatory liberation, the liberation of excitatory pathways. This is a cartoon that summarizes the main characteristic of this encephalitis. This is the mean age at onset is 18 years. It is notably in almost 40% of patients, children are affected. Females are more affected than males because these encephalitis may be paraneoplastic in the presence of ovarian teratoma, and ovarian teratoma, and this explains why the prevalence of female during the childbearing age. The symptoms at onset are different in children and in adults, and in children, movement disorder and seizure and neurological symptoms are the most frequent. In adults, psychiatric symptoms are usually the symptoms of onset, and adolescents are in the middle. The symptoms may be summarized as follows: with sleep disorders, severe insomnia, psychiatric disorder that may be overt and dramatic, or subtle and insidious would be change behavior, particularly in children, hyperactivity, irritability, loss of interest, language disorder, autonomic disorder, and movement disorder and seizure. Seizure, movement disorder, and psychiatric symptoms are the three more dramatic symptoms that must be recognized and differentiated by each other, because sometimes it may be difficult to differentiate movement disorder from seizure, or a seizure from psychiatric symptom, or psychiatric symptom from movement disorder. And this is to underscore how important is the clinical observation and the video EEG monitoring. Patients may have dysautonomia, as in this patient. You probably may see that the patient is, okay, it works. The patient is hyperventilating, and there is an EEG showing delta activity, periodic delta activity more evident on the frontal area, in the anterior region. And we can have tachybradycardia, hyperthermia, and this kind of dysautonomia. But I like to show you a typical patient, a typical adult patient that have been tested by my own. This is a boy that's 16 years old. You see the patient is in a catatonic state, unresponsive, with rigidity of the upper limb, with the trochlea sign. He does not react. Is hypomimic. He does not react to pain stimulus, and this is quite typical. And further, these patients may show Does it move? No. No. They may disclose a bizarre movement. This is a girl, a 12-year-old girl, with this that act as a dance. These bizarre movements are quite frequent in this patient. Have you seen this kind of dance? Or in this case, a patient has a movement like playing piano. Okay, and this is what we most see in the adolescent patient with movement disorder that are very typical and particular. In children, movement disorder, and the patient mostly present with a dyskinetic movement disorder. As you see, they are feeding by gavage because of the difficulties in feeding. And we observe all this kind of hyperkinetic movement disorder that may be very severe with opisthotonus, like in this case, or with repetitive automatic movement. I skip. Of course, we have seizure in this patient. And how are seizures in MDR encephalitis? Sometimes seizures are very recognizable, very clear, like in this case, that you can, both from a clinical ground and from an EEG ground, can recognize that there is a motor seizure that involves the right face and the right arm with a clonic movement.
Sara, chiudi gli occhi.
But in other cases, seizure may be very subtle and difficult to recognize, like in this little boy. He has this discharge, this ictal discharge, but on the clinical ground, you can miss the presence of seizure. Or like in this other boy, again, you can see the ictal discharge on the EEG, but there is no clinical event evident. And then we have patients that present paroxystic movement that are difficult to define, particularly if you take the history and you don't see the patient. Like this patient that has been referred for the presence of a focal clonic seizure, but when recording, we demonstrated that there are no ictal activity on the EEG, but that this movement was indeed a movement disorder, a focal movement disorder characterized by the dystonic posture and the high-frequency tremor of the arm. And finally, I would like to present a patient because sometimes we have movement disorder and seizure that are strictly intermingled, like in this patient that was referred because she was not able to walk because of continuous movement, continuous tremor of the lower limb. And she was referred to us in the suspect of epipartial continua. But if you see the video, there is a mixing paroxysmal motor disorder. Here you see the dystonic posturing of the foot and continuous movement disorder and movement disorder during wakefulness that is continuously variable in the semiology. But if we see again, we see the movement disorder during the sleep with continuous movement, but at once you will see that the movement disorder change, became more rhythmic, and you'll see a ictal discharge on the EEG. So this is the movement disorder. If you see the polygraphy, you see the irregular movement disorder. And now the disorder becomes more rhythmic, a clonic movement with a nictal discharge on the central, the contralateral central region. This is to exemplify how movement disorder and epilepsy may coexist in the same patient and during the same paroxysmal motor phenomena. And this is more clear. We have the movement disorder, continuously variable and no ictal change, and then the clonic movements and the ictal change on the contralateral region, on the central and vertex region. So I think I have to move to the treatment. The treatment, of course, is made by treatment of the etiology, so immunotherapy, and we have a first and second line treatment and tumor removal in patients with ovarian teratoma, and symptomatic treatment of the different disorders, seizure, movement disorders, sleep disturbances, psychiatric symptoms, and dysautonomic symptoms, and we have not to forget the rehabilitation of sequelae, because these patients often have a cognitive disability that may persist over time. This is our scheme of treatment, and I would like to discuss with Mark Carreño what do they do. So as a first-line immunotherapy, we use methylprednisolone at high doses for 5 days and then slowly tapering in other 5 days, together with intravenous immunoglobulin over 3-5 days, or someone prefer to use plasmapheresis. We usually use immunoglobulin. If patients respond in this treatment, and I mean, when I say the patient respond, I mean that we see an improvement. Of course, we do not have a magic effect of disappearance of all the symptoms, but we see there is an improvement, and we use the modified ranking score for children to evaluate the improvement. But if after 2 weeks the patient do not respond, there is no improvement, we move the second line immunotherapy with rituximab, or more rarely with cyclophosphamide. In patients that are responders, we maintain treatment with oral prednisolone. And of course, there is the symptomatic treatment of all these, of all the symptoms that I have mentioned before. But may I ask Mar to come and to discuss with me your attitude to treatment, because I had some questions for you.